And I'll carry on with my talk. This is a rather contentious issue. So let us look at what we do in India. So these are the three ways we are using Avastin right now. We prepare Aliquots. Can I have the pointer? Pointer. So we prepare Aliquots. In contrast to the West, for instance US, there is a compounding pharmacy which prepares the Aliquots for the people who use it. But then in India, we prepare the Aliquots ourselves. Most of us do that, except in AIMS, where there is a compounding pharmacy where they prepare Aliquots of Avastin into small vials and for the use of, within the use of AIMS, not any other institution. Everywhere else, wherever we prepare Aliquots, we prepare them ourselves. Then otherwise, they pool patients and give. And third, the most common being the reuse from a single vial. So if we were to prepare Aliquots, how we do it, I will show you how we do it at Shankara, and this is the system I've been doing for the last 6 to 8 years actually. So we do it in a laminar flow hood, which is there in a cornea clinic in most of the places. This is cleaned with a Bastoside solution or any surface disinfectant solution. Then the UV light is switched on for about 45 minutes. Then the person who is going to aliquot it and the assistant, the sister, they scrub, they don a cap and a mask, and a glove, and a gown, and then do it under this laminar flow hood. So we use a three-way stopcock, so that way there is no air going into the syringe, and we withdraw it into 1 cc syringes about 0.1 ml. And then how do we store it? We put them in a Ziploc bag. So these Ziploc bags are ETO sterilized and they are double packed. So there is one inside the other. So these syringes are put in Ziploc bags and they are stored in boxes like this, which are once again ETO sterilized. So these boxes are stored in the refrigerator door at 4 degrees centigrade, and the refrigerator of course has a UPS connection also. So as I mentioned, preparation of Aliquots, some of us do it under the laminar flow hood, and there are some of us who do it in a OT with a laminar flow hood as well. So which is better, I don't know, but this is an accepted method even in the preparation, even in documents from the US and Canada have shown that laminar flow hood is an accepted method. So what do we do subsequently? As soon as it's aliquoted, the first specimen is sent for culture. We wait for 3 days to make sure that there is no growth of culture. Then subsequently we start using it. So, and again, one more specimen is sent for culture at the end of 1 week. And we use the Avastin within 2 weeks, or whatever is left over, we throw it away at the end of 2 weeks. So after 2 weeks, we don't keep it on. So what are the advantages of this system? So any patient who walks in, we don't have to tell them you come on this particular day, that is when we give Avastin. So we can treat them right away. And the risk of contamination is minimal and allows periodic culture. All we need to do is send one syringe for culture. We don't have to poke the vial multiple times. And in case if there's going to be a reaction, because we are treating the patients over a period of time, as soon as a patient develops a reaction, we know that like there is a possibility, then we can stop it and then reanalyze it. So you may not have a bunch of endophthalmitis happening. Disadvantage, because we are withdrawing about more than about 0.1 or 0.2 ml into each syringe, there's a possibility that you may not get the full value for a particular vial, because you may be getting about 20-25 syringes. And the facilities to fractionate may not be available with all of us. All of us may not have a laminar flow hood in our institutions or in our clinics. So that is a problem. And any of these techniques which withdraw into a syringe, what happens is all these syringes are lubricated with silicone oil. So sometimes when we inject, some of the silicone oil in the syringe can go into the vitreous cavity, and some of the patients may have noticed these little bubbles. So there can be contamination of the Avastin from the silicone oil which is in the syringe. So the silicone oil is in the syringe as a part of the manufacturing process. So what happens to the stability of this repackaged Avastin? So here we have to understand the limitation. All these studies have been done in the US or wherever the compounded pharmacies are. How we can extrapolate this data to our situation where we repackage it in our own clinics or hospitals is something which is difficult. We don't have data from our own institutions. So they have found that like the Avastin which is repackaged into a syringe is stable for about 3 months. A couple of studies have done that. But there are caveats also. So there are studies which have come up with the negative side of it. So though there are no microbial contaminants or endotoxins in these repackaged syringes, they have found that there is significant variation in the protein concentration. So the Avastin from one syringe to other is variable as compared to what is drawn from a single vial. directly from Genentech. So you withdraw it into a syringe and store it for some time. There is some change which happens within the syringe, within the Avastin. Yet another study showed that the protein tends to aggregate. It tends to form larger molecules, larger floccules within the syringe. And the silicon oil microdroplets is also a concern because the silicon oil is in the syringe into which we withdraw. So again, I emphasize this. These are studies on drugs from compounded pharmacies, not from our own practices in India, because we store it only for about 2 weeks, not for 3 months. It shows that the Avastin may change a little bit. How it impacts, we still don't know. There can be protein aggregation, there can be lower concentration of drug, and there can be silicon oil droplets within the syringe. Coming on to the second common system which we use, which is patient pooling. So call the patients on a particular day, give the Avastin completely, exhaust the vial and send the patients back. So here again there are multiple systems. One is we can inject and withdraw multiple times. So we have 10 patients on a particular day, withdraw 10 times, give them and then throw away the vial. Or you can draw it into multiple syringes at the beginning of the day in the OT, keep it and then bring the patient inside, inject and send them back. Third, some people use it in a master syringe and then put it into multiple syringes and give. These are the 3 techniques of patient pooling which is being used in India. So is it safe? So study is there. So on a particular single day, you can put the drug back into the fridge, pull it out, withdraw, inject. Put it back into the fridge, pull it out, withdraw and inject. You can do this 10 times of a particular vial and then throw away the vial at the end of the day, and has been found to be safe. So this study shows that they have been doing this for about a year and a half and found it to be safe. Yet another report says that the same thing. You can withdraw multiple times at the same time or put it back into the fridge and withdraw. This is all, please remember, this is all in a single day. At the end of the day, the vial is thrown away. This is not stored for the subsequent use. So you can puncture the vial 10 times or even more. Only thing is, we need to wipe the cap. If you are going to put it back in the fridge and take it back and use it on a single day, wipe the cap with alcohol. So this cap contamination is something which is to be avoided. So what is the advantage of pooling? So we are using a new vial on a particular day and throwing it off. So the effect of, we don't store it, so the risk of contamination is much lesser. Disadvantages, we are going to call about 15-20 patients on a particular day and give it in the theatre. So there's a lot of turnover in the OT. So that can result in OT contamination to a little higher extent. And if in case you land up with a spurious drug, this is where the problem comes. Then you have a bunch of patients. All the patients who have been treated on that day are likely to develop a problem. So this is going to be the problem with the pooling part of it. Silicon oil from the syringe again is the same, because we are withdrawing into a 1cc syringe and giving it to it. Let's come to the most common system we use, reuse from a single vial. So if we were to use from a single vial, we have to wipe the cap with either any alcohol more than 70% in concentration or a 10% betadine, or we can use both as well. Use alcohol followed by betadine, then poke the vial. So if we were to draw, we have to draw with a new needle, taking care to prevent air from going inside, and best is to draw after scrub, gown and glove and a mask. Advantages of this system is it's easiest for an individual ophthalmologist. You don't need a laminar flow hood. You can put it in the side door of the fridge, pull it out and use it. You can treat the patient as the patient comes. You don't have to store it. The disadvantages, there is lingering possibility of infection, because the microbiologist will say you poke the vial, then that means the sterility is gone. So is it true or not? We don't know. So they say there is always that thought there that like it's likely to be that the next patient we are going to treat is the patient going to be all right or not. Is it an approved method? Again, we don't know. Is there literature support? There is some literature support studies done in 2009 and 2008 where they have showed that like you can reuse the vial multiple times and store it for about a month. It's safe. There have been studies where they kept it for 6 months, but I really wouldn't suggest that you keep it for 6 months if you're going to follow this technique. So up to 4 weeks, multiple punctures, storing it in the side door of the fridge may be safe. So let us look at some of our own Indian data. Sometime back when there was a bunch of endophthalmitis going on, I did a little survey on the retnet forum. So 78 respondents were there. This includes large institutions also. So 47 of the 78 directly withdrew from the vial. So 14 of us were making aliquots, and patient pooling was followed by about 8 of the 78. So which is the best method? I'm sorry, I can't really answer this question, but like the proof of the pudding is in eating it. So let us look at the endophthalmitis rates. So out of the 78 people who responded, 67 did not have endophthalmitis. So about 11 of the people who responded had endophthalmitis. So out of this, 5 of the people who were directly drawing from the vial had endophthalmitis, and patient pooling 3 institutions and Aliquots 3 institutions. So this is the breakup. So you can't come to any conclusion as to which is better, which is not better. But look at the number of people who had endophthalmitis. So in patient pooling, 25 patients from one institution, 20 from one institution. So there's a large number from a single institution, from a single bunch. So this is where the spurious drug part comes into it. So once there is a spurious drug, all the patients you have given on that particular day are going to develop reaction or are going to develop an endophthalmitis. That's clouding up the data, though the patient pooling is probably one of the better methods, but then because of the availability of spurious drug, we are having a lot of issues in sorting out which is the best method. So storage part of it, though it is recommended from the compounding pharmacy in the US that you can store for 90 days, I wouldn't suggest doing that in India. Best is to, as I mentioned, we store it only for 2 weeks. But the most common practice seems to be storing it for 4 weeks. And if you were to store it on the side door of the fridge at 4 degrees centigrade, and make sure that the fridge is connected to UPS and there is no loss of power. So to summarize, Avastin usage appears to be generally safe from the microbiological part of it, not from the systemic safety part of it. And there is no clear-cut evidence of one method being better than the other, and this result is confounded by availability of spurious drug in India. So we are in uncharted land as far as use of Avastin is concerned, even today, though we have been using Avastin in India for the last 8 years or 9 years. All of us are open to litigation, because we don't know about the status of the off-label drug use as well. So best is to follow safe practices to protect ourselves. So best is to clean the vial cap with more than 70% alcohol plus betadine every time you use it. Best is to use the scrub, gown, glove, mask, and discard after 1 month of opening the vial, and buy from a certified sources, and always be on the lookout for a red flag. Thank you very much.